kind introduction. Today I'm going to talk about a subject that was suggested to me by Dr. Al-Omari. It is not about the cornea. The lens is getting old. Let us replace it. Is this true or false? Is this ethical or not? We are going to try to find out together. Of course, President, how we change the slide from where? From where we change it? From where? Okay. So presbyopia is the last frontier in the refractive errors that we all try to find an effective, safe solution to it. Of course, the most popular treatment for presbyopia or correction of presbyopia is using the glasses. The glasses can be only reading glasses or bifocal or trifocal or progressive multifocal or office progressive, which I actually use it a lot these days. It is aimed only at the distance of the computer and the distance for reading, and the patient or the person has to leave it when he leaves the office. Contact lenses, we have bifocal, mono vision contact lens, one eye under corrected, one eye full correction, and the modified monovision, both eyes for far but with one lens bifocal. Refractive surgery, of course, the presbyopia, refractive surgeries, there are so many. The oldest and the most adopted by many surgeons worldwide is the monovision LASIK, in which one eye, the dominant eye, is corrected for far and the other eye is corrected for near. We have to check the stereo acuity before we do this, or we suggest it to our patients. It's a very good technique, since the reversal is possible in these patients. And the problem is the retreatment rate is 17%. It is considered to be high. This is after review of the literature. And why it is high? Because these patients with one eye for far, if the far vision is not very sharp, they are not going to be happy with the monovision, and the retreatment, we do it on the dominant eye for distance vision. Multifocal LASIK, by making the corneal multifocality, creates more than one focus, one for far and one for near. This is called the Presby LASIK. There are many ablation profiles to correct this, but unfortunately, again, the retreatment rate is 21%, and there is 12% loss of two or more lines of corrected distance visual acuity. We have the intracore, in which with the femtosecond we create concentric rings intrastromal. This will lead to central ectasia, creating an area for the near vision. There is 9% loss of two or more lines of best corrected distance visual acuity. The supracore is like the intracore, but using the excimer laser, not the femtolasic, after creating a flap. There are trade names like the Presby Max and the Presby Beyond. It depends on the laser platform used, but they all depend on creating multifocality in the cornea, and usually one eye is more for near. Corneal inlays, there are in the market three. The most common is the camera inlay, depends on the pinhole principle, leading to extension of the depth of focus. The good thing about it is that it is completely reversible. The challenge is the centration. Another two corneal inlays, one depend on the creating microscopic elevation in the center, and the other one with different refractive index than the cornea. When we look at this, we will see that most of these procedures, they have retreatment rate, in my opinion, is a little bit unacceptable. And the only two techniques that are completely reversible are the monovision and the camera inlay. The complications of presbyopia surgical corrections are decreased corrected distance visual acuity, night vision problems, decreased contrast sensitivity. The patients might get one or more than one of those, difficult reversal, especially in multifocal cornea, ectasia, decentration, visual disturbances, and the binocular stereo acuity. Um, I've been involved in the trials for presbyopia correcting lenses in cataract patients since the very beginning of these technologies and IOLs. This is my first published paper that seems to be coming from a museum that was published in 2005. It's about the Restore, which is a apodized diffractive intraocular lens. I also studied the zonal refractive and the zonal refractive and the diffractive. But when we ask the doctors, our colleagues, why you don't use presbyopia correcting IOLs, the almost 80% of them, they say because of the visual disturbances, starburst, glare halos, and half they say because of the decreased distance vision, 1/3 because of they don't want to be perceived as selling a product to the patient. Quarter of the doctors because of the extra work pre-operative and post-operative and the chair time. Quarter of the doctors also because they follow the patient request. If the patient, they don't ask for it, they don't offer it. And 10% because they don't have enough experience. The main requirement, this has been, why there is no lens that it is ideal for the presbyopia correction because, or the corneal techniques, because the main requirement for presbyopia treatment is extended binocular. So the technique has to be binocular. Depth of focus to yield adequate distance and near vision with good retinal contrast at lower spatial frequencies. This has been said by Charman in 2004. We know that wavefront shaping is the next generation in IOL presbyopia correcting lenses. Before we had the refracting lenses which bend the light, or diffracting lenses which split the lights, all this creating more than foci, leading to the creation of visual disturbances like halos and the starbursts and the glare. But wavefront shaping is a new concept that lead to the extension of the depth of focus without the creation of the visual disturbances. When we look at this, the lens that I currently use, I don't have any financial interest in it. It is the Vivity from Alcon. We have in the center of this lens, there is a transition zone 1 and the transition zone 2. It's only elevated by 1 micron, which is smaller than an RBC, the elevation. When the wavefront passes through the lens, the part of the wave front emerging from the thin part of the optic is advanced and is extended. What, finished? Yeah, is extended forward, and the part passing through the center of the lenses, the transition zone, is extended backwards. This will lead to a stretch and compression of the focal point. So when we look at the performance at the point, I forget. When we compare the wavefront modification technique compared to the refracting and diffracting lenses, we will see that the modular function here in the monofocal, they can only, the focus is for the distance, and the extended depth of focus for distance, for intermediate, and some near, not very close up to the face. So the unmet needs still by presbyopia correcting lens are the reduced halos and glare, monofocal mesopic contrast sensitivity, ability to perform functional activities, and complete spectacle independence. None of the lenses fulfill all that. تقول للراجل يحل عنا بقى. طب خلاص يلا. Okay, thank you. Next year.